Awesome. Okay, let's do this. Let's do this. Okay. Okay. Hello and good evening, everyone. This is Mo. Just so you know, I'm a periodontist working at Cityview Periodontal Center. I'm super grateful to all of you for joining us today and giving us the opportunity to talk about different topics. I'm especially grateful for the fact that I've been given the topic that I absolutely love doing and talking about, which is gum grafting. Given we only have about 10 to 12 minutes or 13 minutes or so for this particular session, let's just get right into it. Let's just get into our topic, which is gum grafting 101. Let's do this, shall we? Okay, now, before we start, I want to ask you all a very simple question, very straightforward thing. What if you get this in your practice or you see this in your clinic? Now, before we jump into it, let me explain what you're looking at. So you're looking at a patient, lower front teeth are visible, 6 and 5 that is. If you watch closely, this is the tooth number 4-1. You can see that there is severe recession, almost the entire root. In fact, if you look, it's going beyond the flap. So it's really severe gum recession. The other thing is there is no buccal bone, none, all is gone. The tissue seems quite thin. Then if you watch closely, you can see the frenum is pulling the area as well. Now, if you really watch closely, you'll be able to see this line, which separates this good quality tissue known as the gingiva from this poor quality tissue known as the mucosa. And this is the line which is called mucogingival junction. Now, if I was to take a probe and put it inside, and if it extends up to this line, we call it minimally attached gingiva or mucogingival involvement. Now, but coming back, you see a lot of bone loss, you see severe recession. So what do you do in a case like this? What do you do? Before we get to the solution, let's take a step back and let's first define or talk about what is gum recession and what is gum grafting. Okay, so what is gum recession? Gum recession is the apical migration of the gingival tissue. Simply put, when the gum starts to drop down and the roots become exposed, that's what you call gum recession. How does it look? Let's have a peek. So this is what you see, okay? So you see a little bit of recession here, some recession here, some here and here. In case you were wondering, these 4 dots, they are from the local anesthetic. So the LA has already been given, okay? Now watch closely, you can see there is good quality tissue, the gingiva between the teeth in the papillary area, but we have mucosa. We don't have good quality tissue underneath the teeth. The other thing is the cheek and the lip is slightly retracted, and you can see there is 0 vestibule. So that means when you eat, all the food particles can easily roll off, enter the sulcus, and destroy the underlying structures, the periodontium, which you don't want. So this is gum recession. Then what is gum grafting? Simple. The periodontal procedures to correct this problem is called gum grafting. Could be connective tissue, could be free gingival graft. So what we want is we want to change this issue, the problem that we have with a lot of recession, no vestibule, not good quality tissue. We want it to be fixed and transformed into, boom, this thing looks beautiful. So in this case, you can see all the recession is pretty much eliminated despite the fact that we have quite a lot of calculus. So this image was taken about 3 weeks post-op. Complete root coverage, looks beautiful. The other thing is, which a lot of people don't notice, this is the vestibule now. You can see how tall or long this vestibule is versus this area. Also see, this is the mucogingival junction, and it's only 3 weeks. It will only get better, but it already looks beautiful. And the tissues look bulky, strong, robust. This is what you want. So this is basically gum grafting. Now that we know what is gum grafting and gum recession, let's look at some of the causes of gum recession. So what causes gum recession? Turns out plaque, calculus, the inflammation, typical thing, then brushing as well, if you're especially using hard brushing like I do sometimes. Frenum pole would lead to that as well. If you don't have good quality gingiva, like if you have mucosa, like we discussed just in the last slide, that could also be associated with recession. Positioning of tooth, look at this tooth. It's a lot of recession and wide recession, and it's completely out of alveolar housing. Not a good situation to be in. Tongue ring is associated with lingual recession. Thin biotype is also associated with recession in periodontal disease as well. On a side note, in case you were wondering, this particular case, we were able to get complete root coverage, turned out beautifully. And as we speak, it's already in the press. So it's been accepted as a case report, and it's coming up in the next few months. So it turned out quite well. Now we know the causes. Let's have a look at the consequences. What happens when you have recession? What does it do? So it can lead to compromised aesthetics, more plaque and calculus retention, some sensitivity, root caries, non-carious cervical lesions. But the important thing is, think about it this way. You can have buccal bone loss. Let's look at this area. There is no bone. So what happens when you don't have bone? It can compromise the support of the tooth. So not cool. That's not good. A question is, a lot of patients ask, they say, okay, I have recession. What if I don't get treatment? Will it progress? Will it get worse? Let's look at the literature to answer that specific question. Turns out, if you have a 3 millimeter recession, just 3 millimeters, there is about 60% chance it will get worse. And if you have 4 millimeter recession, almost 100% certain it will get worse. Now, the interesting thing is, if you watch this, from 3 to 4, it's a change of 1 millimeter. But the change in the likelihood of progression, almost 40%, meaning once you've reached a certain threshold around 3 millimeters, the recession will just get worse and worse. And as it gets worse, it's more difficult to treat. So the wise thing is to try and fix it earlier. Okay, so now in this case, you can see, for example, we're looking at the tooth number 26. We can see on the mesial aspect, there is recession. Now the patient had it, and I saw the patient for the consultation, and the patient said, yeah, you know what, it's okay. And then 12 months later or something like that, patient comes back with this. And now you see it has progressed already, and we are already in the area of the mucosa. So we managed at this stage. It turned out really well. We were able to, completely eliminate the recession, but it's wise to manage it at an earlier stage. Okay, so we know that we can do a connective tissue graft, we can do a free gingival graft, but what are some of the other goals that we want to achieve, not just the root coverage? What are some of other things? So the other things they include, we want to create attached gingiva. We want to create thick tissue. We want to eliminate the frenum and increase the vestibular depth. But again, from patient's perspective, a lot of times their main goal is this, root coverage. And they ask us a lot of times, can you predict or can you really know how much coverage is likely in a particular case? Turns out there's a classification that we periodontists tend to use a lot, which is known as Miller's classification. To make it very simple, very easy, I will say, always look at the interdental bone. So in the first two cases, class 1, class 2, typically the interdental bone, interdental tissues are present, easy cases generally speaking. But when the interdental bone goes away, then the root coverage becomes unpredictable. You cannot really predict complete root coverage, for example. If you really watch closely, you can see that there is this small tiny black dot between these two teeth. So it's the beginning of the appearance of black triangles. So that tells me the interdental bone is missing in this area. Maybe it's just the initial phase, but still. So once you have the interdental bone missing, even if it's a little bit initial loss of the interdental bone, the possibility that you will get complete root coverage is very minimal. So the wise thing is, what I do is I tell my patients in a case like this, or when the interdental bone loss progresses, I tell them straight up that the main goal is we want to increase the thickness of the tissue, make it much more robust and stronger, so it can resist future recession, future buccal bone loss and attachment loss. We might get a little bit of root coverage, but I cannot guarantee you. So this is an important factor, so that we set the expectations straight. Okay, now that we've discussed that, let's dig into the techniques themselves. Okay, this is interesting. This is one of the techniques we talked about earlier, free gingival graft. So once again, what you're looking at, I would like to focus the attention towards tooth number 4.1. You can see there is a little bit of recession in the area. There is frenum pull in the area as well. But the important thing is, look at this. This tooth, 3-1, has a little bit of keratinized tissue, where this one doesn't have any keratinized tissue. And you'll see in the pictures that makes a huge difference. So patient did not have any treatment. My colleague saw this patient, and after I think 12 months or 8 months or so, patient came back. And then I saw the patient this time around, and this is what you see. So you see it's about 3-4 millimeters of recession already. But look at the other tooth, not that bad, not that bad. Why? Keep an eye on this keratinized tissue. It's not very thick, not ideal, but it's still present, versus here, not present at all. So when we open it up, this is what it was. And we open it up and let's see how it looks. Boom, look at the bone loss, a lot of bone loss. And notice this, there is bone loss on the other tooth as well, but that, although not optimal, but still the little bit of keratinized tissue, it was much more protective compared to the mucosa. So in this image, it doesn't look that bad compared to, let's say, this. And here, wow, a lot of bone loss. So what did we do? We had this, we opened this up, we went to the roof of the mouth, we took a small piece of tissue and we placed it in that area, and we really sutured it up. So once this is done, we let it heal for about 2 to 3 weeks. And then what do we get? This is what we had. This is what we did. And boom, this is what you get now, okay? Looks beautiful, looks amazing. Complete root coverage. And look at the thickness, how robust this tissue is. And this image that you're looking at, it was just taken, I think, 2 or 3 weeks after the procedure. So it only gets better as the tissue ages, but it looks amazing. This thing will stay for the rest of the life. Like, it will protect the bone. It's like winter tires double studded, super strong. So this is one of the ways of doing gum graft. Now let's look at the other technique. This is the other technique, connective tissue graft. Very sleek, very nice. The interesting thing is, in this particular image, you're looking at tooth number 1-3 with recession of about 3-4 millimeters, and the recession has already started at tooth number 1-4. But the interesting thing is, in this particular picture, all the incisions have already been given. Everything that needs to be done to prepare this site for the graft, already done. It's very sleek. You can see there are no incisions. The papilla are intact. It looks beautiful. Once the site is ready, what do? I go to the roof of the mouth and I take a small graft. Once the graft is taken, we close the roof of the mouth completely, primary closure. How does it look? Let's have a peek. This is how it looks. So this is my incision line. You can see it's a single incision. It's a closed wound, completely closed wound. These are the sutures. You can see dissolvable sutures. These are the palatal rugae. But the interesting thing is, it's a closed wound. In terms of discomfort, very, very manageable. It's not an open wound. And we've already taken the graft from this area. So this is after the graft has been taken, and it looks beautiful. So once we've got the graft from here, this is how the graft looks. We just position on the recipient side, position the graft, make it so that, you know, we are happy, we have a look, okay, it looks pretty good. Then what we do is we put this thing under the existing gums. So from here, boom, we go here. We just take this graft and we put it under the existing gums. So instantly you can see the tissue looks bulky, strong, and thick. Once we have done that, this is what we had. And then all we do is just suture it up. Simple, easy. Once it's done, this is how it looks. So this is what we had before. And 2 to 3 weeks later, at the post-op, boom, this is what you see. Beautiful. Complete root coverage. You see how bulky, strong, and thick this tissue is. And again, this is just 2 weeks, 3 weeks post-op. It will just get better. So this is connective tissue graft. This is very sleek, very beautiful, very simple procedure, very easy, very predictable procedure. Protects the bone, and it's very aesthetic as well. So when we started this particular session, I showed you this case, and we went from here to here. It was really nice. But what about the other case that I showed you in the beginning? What happened to that case? Which was this case. So what happened to this case? Well, it turns out, despite severe recession, severe bone loss, and a lot of problems. We were able to fix it like this. This is how it looks now. Looks beautiful, looks amazing. And it's been stable for over a year now. Patient is really happy, makes me happy. So this would be pretty much it. But before I call it a day, I would request you all that next time when you see a case of recession, don't just think about aesthetics. Don't just think about sensitivity. Think different. Think about attachment loss. Think about buccal bone loss. Think about gum graft. I look forward to seeing you all, meeting you all in person in future. Till then, stay safe, stay awesome. This is Dr. Mo signing out. If you have any questions, shoot them in. I'll be happy to answer. Super grateful, really appreciate. Thank you.